Good evening, everyone, and welcome to another ASA QA. My name is Linda, and I'll be moderating tonight's QA. Our guest tonight is a young physician, Dr. Haig Aintablian. He's currently an emergency medicine physician at UCLA, also the president of the Armenian Academy of Emergency Medicine Resident and Student Association, and he has been one of the frontliners fighting the novel COVID virus. Welcome, Haig. It's nice to have you tonight.
Thank you. Nice to have you. Nice to be here.
Thank you for accepting our invite. So, I posted on my social media, and we did also post on our social media, the ASA one, asking people to send us some questions. And we already received some even before starting the event. And it was very exciting to see that there was that much interest. So, first, I would like to start from your background. We want to know, I mean, you have an impressive background, and what made you interested in practicing medicine, and why particularly the ER?
So that's a good question. All my life, I've been kind of surrounded with medicine. My dad's a pediatrician. My uncle's a cardiologist.
Okay.
And early on in my life, I kind of saw how much my dad worked. I saw how much my uncle worked. And I kind of thought, this is like a job that you never leave. And I always wondered, like, how could you love something so much that on the weekends you'll go take call and go to a hospital? Sometimes you'd go to the zoo or the museum, and then he would have to leave because he got a page. And seeing that, it kind of was an interesting prospect. In college, I did a lot of scientific work. I published a lot for DNA, like replication changes. I always loved the sciences, loved astronomy, loved biology. And I started to be fascinated with how the human body works in space, how the human body works outside of like environments that we're so used to. I applied to medical school while I was getting my master's degree, and I got into a few medical schools, and I decided that that's what I would do. I ended up falling in love with medicine while in medical school, to be honest. Like I understood what the role of a doctor is. A doctor is not only a scientist, but an artist, and it fascinated me a lot because I get to take the science that you learn so well, and you get to apply it to people firsthand. Later on in life, towards the end of my medical school career, I realized that I love everything in medicine. I couldn't focus on a specific organ. I couldn't focus on, like a specific pathology. I loved everything. And even more than that, I loved when everything was under pressure. So the ER fit me really well because you're always working high stakes. Yeah. It's always an adrenaline rush. Every day is different. You go to work, you don't go to work thinking, oh, I'm gonna have a typical day. You have no idea what you're gonna walk into that day. And I love that about the ER. It's very spontaneous, and it's an adrenaline junkie's dream for.
I can understand that. I mean, I don't understand the stress part. I'll get to your post later on, but that was very interesting to me when I saw it. So we want to hear about your journey. What is the most rewarding part of this?
This in general, or currently in these times?
Well, in general, actually. Yeah.
The most rewarding thing for me is that I get paid to help people. Like it's a very bizarre thing to me because when I have a day off, I kind of want to go back to work because sometimes it's more fun to go to work than it is to, go do hobbies and stuff. Obviously you need your time off, but I get to help people every single day. My job is to save people's lives. And that to me, it still doesn't, I can't really understand it. I'm still trying to figure that out. And it's all of my colleagues too. It's such a beautiful journey because the wins that we have aren't monetary. It's not like, we did something that's like morally questionable. Our wins every day are that we got someone that was about to die and we brought them back to their families. And that's the most rewarding thing for me. And then on top of that, I get to study some of the most fascinating science and apply it to people every single day. And these people trust me enough to be able to do that. And it's amazing to me.
Yeah, I can understand that. I mean, I'm not in your shoes, but I can envision it. So tell us about a day at the ER. How does it look like from morning to the evening, or night shift? I'm sure it's not just morning to evening.
Every shift is different, and this is across the nation. Every shift is different. You'll walk in one day and it might be a calm day. You're fixing lacerations, you're fixing broken bones. No one's really like crashing and burning on their deathbed. Or you might come another day and there might be like 16 motorcycle accidents. There might be a few strokes, a few massive heart attacks. You know, you'll get the run of the crazy people in jail that have stuffed some weird thing inside a body orifice. You know, like you'll see a lot of different things every single day. So there's no typical day in the ER. And that's one of the reasons that I got attracted to it, was because you never know what you're walking into. The craziest days for me are the ones where the pathology doesn't make sense. For doctors, it's not difficult to understand how to bring someone back to life or to kind of fix their main thing. The most fascinating thing for us, especially in the ER, is whenever someone comes in with a complaint where you're not entirely sure what it is, where it's something that kind of reaches all the way to the back of your brain, all the way to that one small fine print in medical school textbooks. And those are the most challenging but most rewarding days too, when you get it right. Yeah.
Interesting. So I saw a few days ago you posted about a nightmare you were having. If you remember that post, that you just woke up and you were screaming and I think ordering
Yeah.
people to do things. So I want to know how stressful it is to work at ER. This is mainly for people because we do have lots of students also who are members of our organization. So I want them to know how it feels like and how it is, so they can kind of have an idea if they want to follow your path. So they would have an idea of it.
I think all of medicine to a certain degree is stressful. Like I mean, the ER is the most stressful of, I think, any specialty, but I think all of medicine is stressful. And I say that not in a negative way. I say that in a way where it's so much trust is ingrained on you, and people's lives are literally in your hands, that you take some of that home with you. The nightmare that you're talking about, I've been having a lot of nightmares during this coronavirus time,
Oh
because
wow.
it's a very bizarre time for a lot of us in medicine, because we don't have a true treatment. We don't have, you know, like something that we could just give patients and make them feel better and make them better. Coronavirus to doctors is like we are kind of working blind and working like, you know, with all the intelligence we have to kind of patch a virus that we don't actually have true medicines for. So for me, like I've had a lot of nightmares lately about, you know, I've caught myself waking up saying get a stat chest X-ray, like kind of, you know, thinking about, and you know, catching myself thinking about how a situation would roll if it came a certain way. You know, if I couldn't do a specific airway maneuver, what would I do next? And it has been really stressful for me lately, but overall, for a lot of us, especially on the front lines in the ER, the type of people that go into emergency medicine tend to be very adrenaline junkie, kind of crazy, and they work well under pressure. So for us, we get really bored really quick. And so
Hmm.
the ER, the constant, you know, the heart attacks, the strokes, the car accidents, like all that stuff to us is a normal day, because we live in that environment. We're so
Right.
used to it. We love that, because it's almost like taking a nice fresh cup of coffee when you see a patient that you're like, I got to do something real quick. Like it's fun. Yeah. But it is
That's
stressful to a
interesting.
lot of people, I'm sure.
Yeah, you already answered my next question because the next question was about the personalities. What type of personality does it take to work at ER? And I pretty much you already answered it. You need to like change and like no
You have
fast-paced
to
work and yeah.
You have to be focused. You have to be very focused. You have to be able to switch tasks really quickly, because a patient will just go. The ambulance doesn't call you to tell you they're bringing a patient. Oftentimes, they'll just bring the patient. And so
Oh
you're
wow.
often switching tasks really quick from like, hey, I'm treating this patient. Oh my God, like the ambulance just brought in this other patient. I got to go check them out real quick. So there's a lot of, you know, attention that you got to switch around, but you also have to be extremely focused, because if you forget one small detail, you know, you could end up hurting a patient real bad. Yeah,
That's true.
personality wise in medicine, it takes a type A personality. I think people are perfectionists that go into medicine. You have to be, to a certain degree, you have to be on top of everything to get into medical school. But yeah, I think ER, we're like a special breed of crazy. Yeah.
That's interesting. Well, I mean, I can't imagine doing what you guys are doing. It's very stressful, and I mean, I admire it because it takes lots of courage, actually, because you're responsible for someone else's life most of
Mhm,
the time,
mhm.
and you have to make decisions right at that moment, and one small thing can just cause somebody to lose their
Totally.
life, maybe. Yeah. So it must be very stressful, and it takes lots of, you know, I would say bravery to be in that position. So, um,
Appreciate it. Yeah.
yeah, I have one more question which came in. This is about our next generation. So the ones who want to follow your footsteps,
Mhm.
what advice do you have for them? Where to start? What to do to become a successful doctor or
So
ER doctor?
I think the main thing that people, when they think about becoming a doctor, they think status, they think money, they think all these things. If you truly think about medicine, medicine is not about status, it's not about money, it's not about any of those things. If you took the amount of work that you put into becoming a doctor and you put it into any other career, you'd be a multimillionaire like overnight. The amount of work it takes to become a physician filters people out itself. And so the thing that I tell all of my mentees, all the people that I kind of coach through, application processes and all that, is you need passion. If
Right.
you are not passionate about medicine, if you are not passionate about the science, every science, physics, organic chemistry, biology, if you're not passionate about all of the sciences, which you will one day apply to the human body,
Mhm.
then this field isn't for you. People often, I hear people say like, oh, if I didn't do law, I'd be a doctor. It's like that doesn't make any sense to anybody in medicine, because all of us went into medicine thinking I'm going to do medicine. The people that made it, at least. No one goes like, you don't just switch overnight into a completely different profession. So I think, with every career, if you don't have passion for it, you're not going to do well. But I think especially in medicine, the bar is so much higher because again, people's lives are in your hand. If you're not going to be passionate, you're not going to be a good doctor, even if you make it through all the filters. And then if you don't have the passion to push you, you're going to be depressed, you're going to be burned out. It's not an easy life. Like being in a hospital in general is not an easy life. But if you're passionate about the human body, then it's fascinating every day and it's beautiful. So I would say that that's the main thing I would advise people.
Yeah, thank you. That was good advice. So, does the responsibility that comes with making decisions on people's health ever take a toll?
Oh, 100%. Yeah, there are days when you go to sleep and you're like, did I do the right thing for that patient? Did I diagnose that patient correctly? And there are days, there are times where I'll stock a patient's chart. Like I'll make sure that they went to their right appointment and they're picking up their medication from the pharmacy, even though I'm not their primary care doctor, solely because it bothers me if they don't. Sometimes you become so invested in a patient that you can't save their life and they
Right.
pass away, and it's devastating. Like there's times where like you're coding a patient for an hour. They're like a father or a mother of like 3 at home. You could tell that the entire family is going to crumble. All eyes are on you, and and you fail. And it's not necessarily that you failed, their body failed, and you couldn't use medicine to bring them back.
Mm.
And you go home at night and you think about that. You drink a beer and you're like, wow. Or whenever a child dies, like people, it's we see the best of the best and the worst of the worst. And the worst of the worst, like, is not something that people have even nearly seen. Like when you see one of the worst cases I had, I won't go into too much detail, was this was in medical school, my last year of medical school, and it was a 8-year-old boy, and a Rottweiler bit their neck, and they ended up dying. And
Oh,
it was like one of the worst things that I had ever seen, because the parents are there bawling. Grandma is there, who's lived her entire life through her life, and now she's towards the end of her life, and she's like, I don't want anything to do with this anymore. And it was so depressing. But again, the you balance the good with the bad. There's a lot more good than there's bad. There's a lot more lives saved than there are those lost. So it does take a toll on you sometimes, but again, we signed up for this. Like I know what I got into, and it's taught me a lot about myself. I've learned so much about what life means. Like I don't fight with anyone anymore. If there's a conflict, I'm like, let's talk about it, or let's just not do this right now. Because I don't think that there's any point to being angry with someone or holding
it's
grudges.
not worth it. Yeah.
Yeah, it's not. You don't know when you're gonna die. Like I see people die at any age without any
Mm.
medical history, and it puts things into perspective.
I can understand that. Yeah, that makes total sense. So, another question. This was interesting. So, have you ever been so scared or regretted um, what you do, even if those moments are fleeting and they just pass right away?
I've never regretted going into medicine or going into emergency.
Hmm.
I've had scary moments. I've had moments where it's like, if I don't do this right in the next 5 seconds, this person's gonna die. There's those moments where it's like, when you have to contemplate like, wow, like I hope I could do this, because if I don't do this, then it is my fault, kind of a thing, or I'm not good enough. Those moments happen. They're not common, but they do happen. Regret, never. I've never. When I learned about medicine, when I went into medical school, At first, I'm like, this is the stupidest thing I ever did. Like because you lose your entire life. You're studying all the time. And I'm like, why the hell would I do this? And then whenever I started falling in love with it, since that moment, there hasn't been a time where I've regretted it.
Well,
Yeah.
that's great to hear. So you're happy where you are. I mean, I could tell already from our previous question answers, but yeah, I'm glad to hear. So I want to move to our current situation. We have some questions regarding that too. I tried to group them so they wouldn't be, you know, from everywhere. So first of all, congratulations on being elected as co-investigator in the clinical trial for the experiment treatment of COVID virus. So is there any update on that? Something that you can tell us? I mean, it's not basically
I can tell you,
non-confidential.
yeah, I could tell you scientific community-wise what's going on.
Okay.
So there's a lot of clinical trials for experimental drugs coming through. And unlike hydroxychloroquine, which was never designed to be an antiviral, we're producing antiviral medications that are specific to viruses like Ebola and COVID. So there's a few treatments coming out. It's going to be a while before you see these mainstream, though. Like medicine doesn't work that way. It doesn't work really quick. You have to make sure it's safe for a lot of people to take. So there's that. I think there's also a lot of research both for and against hydroxychloroquine. So hydroxychloroquine, as you know, is it's an anti-malarial drug. It's a medication designed for people that have malaria, either as prophylaxis before they go to a country that has it, or as a treatment. The medication's side effects, the things that it does to a cell, make it so that it's really difficult for coronavirus to survive in certain circumstances. So this medication, the side effects are great, essentially for what looks like treating coronavirus. But whether or not this thing is safe enough for most people is coming into question because of the fact that the other side effects include heart arrhythmias, blindness. There's a lot of other things. So it's not something that's, I think, is going to be mainstream. What we all need to focus on is vaccination, because since most of the population has not had coronavirus, people estimate that less than 10% of the population has had coronavirus, especially in America. We need to vaccinate those 90+% of people so that they never get coronavirus. That's where everyone's efforts are, because a vaccine prevents disease.
Right.
These medications treat disease. If you never have the disease, then perfect.
Yeah, you don't need to get treated.
Exactly. The treatments right now are not, it's not going to be like Tylenol where you can just take one, and call it a day. This is going to be something where they're very specific medications, very difficult to produce. It's going to take years of clinical trials probably. And we're just going to have to see where it goes. But yeah.
And I would assume for each patient it would be different, because if they have like pre-existing conditions and everything, probably they cannot take those strong medications at once.
100%. I mean, the reason why you see a doctor for your medications is because we need to see what we're doing. Like we need to see, can your body handle this medication? For just about every medication that's not over the counter, we have to think like that. So if you're even taking other medications, can you take azithromycin or hydroxychloroquine? Like for example, azithromycin can elongate a certain part of your heart's cardiac activity. And if you're taking another medicine that does the same, you could end up in a fatal heart condition called Torsades. So there's all these things you have to put together when you're looking at a patient and prescribing medication, and these especially include that consideration.
Interesting. So just to follow the same subject, I was speaking to my friend who she's a sonographer herself, and her husband does MRIs and CAT scans. And after talking to her, she told me that they get lots of COVID patients because they have to basically check their lungs and then the liver function and kidneys. So I want to know, is the virus affecting their other organs, or it's the basically medication that they're taking right now because of that, the treatment?
So based on my experience, as well as the experience of other ER doctors that I know, nationally and locally, what's interesting is we're seeing the virus itself mostly affects the lungs, but we are seeing a lot of patients that start losing kidney function. They start they start having cardiac issues, things like myocarditis, where the virus actually infects the heart too. We're seeing a lot of different ways that this thing is manifesting. The virus itself is not as like whole body as something like Ebola that opens up your vasculature everywhere. But and it typically infects the lungs in the severe cases. But yeah, there are cases where we're seeing, you know, these patients are starting to lose kidney function. Their heart is not squeezing as well, so they're starting to lose perfusion to other organs. So yeah, the other thing too that's coming out now is a lot of these patients are developing clots. So this is a really interesting thing. This is very recent. We're finding out that coronavirus increases your risk of blood clots, things like DVT. Yeah. Also pulmonary emboli, which are clots in your lung that prevent forward flow of blood from one side of your heart to the other, to the rest of your body. So you could die from that. It's a very fatal condition if it leads to that. So we're seeing a lot of things, but ultimately I would say that most of the cases are pulmonary only, with a lot of like a few in between becoming more systemic, full body kind of things.
I can understand that. Yeah. So let's just discuss basically the medical staff situation. What are the general steps that the ER workers have to take to protect themselves? I remember you were looking for this mask, which was like, you know, covered everywhere. So yeah.
So the PPE situation, PPE is personal protective equipment. It's what we call, you know, like the whole gown thing that we wear whenever we're seeing a patient that has something like tuberculosis, something like Ebola, something like coronavirus. The PPE situation initially was horrific across the US. Very few hospitals had stockpiles. In fact, like you started to see just how poorly managed hospitals were and how the US was based on the PPE situation, because we had no stockpiles. Hospitals were running on like a weekly basis of these things, and no one had thought to prepare when China was having this pandemic. So with regards to steps that we take, usually when we see a coronavirus patient, we're wearing a mask, a simple surgical mask, as well as goggles. That usually will help prevent any small inoculum from entering our airway. Whenever we're doing a procedure like an intubation, putting a tube down someone's throat, or doing another thing close to their airway, we're using an N95 mask. A lot of the governing agencies for medicine, a lot of the main groups that oversee us have come out with guidelines saying that you can go higher as long as you're meeting the minimum requirements. So some people are bringing their own P100 masks. That's the one that I was asking for initially. I got one.
Oh, you got one?
Yeah, it's pretty legit, but it's not something that I use on the daily because I don't want to freak everyone out when I wear that mask. Yeah, but we're seeing a lot of, you know, initially we would just wear PAPRs. PAPRs are the space helmet ones that filter everything. Those are incredible devices. But once we started to learn a little more about the virus, we started to use a little less protection, which I don't know if I agree with fully. I think we all should be wearing N95s all the time, but you know, the CDC doesn't say that, and the CDC has come into question by doctors because they've become more political than medical lately, and that's unfortunate.
Right. Yeah, I heard from my friends who are nurses that they were asked not to wear the N95, so they had to wear another mask on top to cover their N95s.
Yeah. And a lot of people are doing that. You see people wearing N95 and then another mask on top just so they could throw away the mask on top. But again,
and at the same time,
this is the reason why I think the CDC is doing it is not a bad reason. It's because we don't have enough N95s for those of us on the front lines. If I were to use an N95 mask the way it's supposed to be used, I would be wearing it one time with a patient, throwing it away. Going to see the next patient, using a new N95, throwing it away. So I would go through like 15 N95s in a given shift. And we don't have enough at all for that.
I know. Yeah. That part is very sad. Yeah. That's really sad actually. It's sad that you guys are fighting this and so many don't have the protective gear to just protect themselves, because I mean I have friends who are staying like I have a friend who's staying in her garage just because she wants to isolate herself from family.
A lot of us are living separate from our families because we don't want to infect them. The other thing too is we know how many doctors have died. Like looking at Italy, there's more than 115 doctors died treating coronavirus. In the Philippines, 1 out of 8 of the deaths is a doctor. You know, so we're seeing coronavirus every single minute in our shifts, and we don't know if we're getting more than one strain. We know that doctors are getting hit worse because you're getting multiple different viral loads from different people. So it's a very, very unfortunate situation for a lot of the people on the front lines, and something that we need to keep fighting for. But unfortunately, these are the cards we've been dealt, and you know, doctors will continue to go to work because this is what we do. This is our Hippocratic oath.
Thank you for your service. I mean, we can't thank you guys
Yeah,
enough because,
you don't think, yeah,
I
it's
mean,
what
you
we've
guys
all
are
seen.
saving lives, yeah, every day.
Thank you.
So, yeah, another question we have is about the patients that, I mean, basically the healthcare professionals that each COVID patient needs. So, what kind of professionals do they need,
You need a
except the
lot.
doctor?
You
Okay.
need a lot. So let's say a sick COVID patient comes in.
Mm-hmm.
So EMS usually brings them in. The fire department will bring them in. That's usually like on the order of 4 to 6 people that have interacted with this patient. The nursing staff, you'll need typically 2 to 3 nurses just to get all the things started in the ER, get IVs going, getting ready for the airway management stuff. You'll need a pharmacist, typically, if we're going to intubate, because they draw the medications really quickly while we prepare for an intubation. And you'll need a respiratory therapist, which is going to have to come in and set up the vent as soon as we get them intubated. So that's just in the ER. After that, you have
Right.
people that transport the patient to the ICU. You have an entire new ICU team that takes care of them. You have the ICU respiratory therapist, the ICU nurses. You have all these other people. What we're seeing in New York is that a lot of these patients, there was no room in the ICU, so the ER became an ER and an ICU. You have to manage these patients over a few days in the ERs, which is not what the ER is designed for. The ER is designed for us to fix you as quickly as we can,
Mm-hmm.
and if we're not going to send you home, then start your medications and then put you in the hospital so that all that course can finish over the next few days. But like in the hospitals that started becoming overwhelmed, like in Italy, like in New York, you started seeing that back up into the ER. But
Right.
you see a lot of staff. I mean, there's a ton of staff that I would say on the order of like probably 15 people like take care of these patients. The people that are most high, that are the highest exposed are typically the procedure people, so the doctors that are doing the intubations, and the nurses that are at the bedside of the patient all the time.
Interesting. Okay.
Yeah.
So, I have another question from our audience. So they're asking if all the patients come in with the same symptoms, or we are reading different symptoms all the time. Okay.
So many different symptoms.
Mm-hmm.
So, for example, so the typical coronavirus case is a patient that comes in with fevers, dry cough, and shortness of breath. That is the textbook coronavirus, COVID-19 case. The patients that you see in real life are people that anywhere from they just lost their sense of taste and smell, which is now very specific to coronavirus because the virus itself can actually take your sense of smell and taste away based on where it infects in the oral pharynx, all the way to myocarditis, which is the patient's heart is infected with the virus, and now the heart is inflamed, and now the heart isn't pumping well. Instead of squeezing to get blood to the rest of the body, it's kind of quivering, which is not a good sign. So anywhere in between those. The patients that become typically sick requiring a ventilator and all that, they develop a viral pneumonia. They develop a viral pneumonia where the virus, the coronavirus, instead of just infecting the throat, it goes down to the lungs, infects the lungs, and then your body tries to fight the virus, and in doing so damages the airways, the little pockets, the little alveoli, the little pockets that exchange oxygen in your lungs. When your body attacks it, it leads to leakage of fluid into the air spaces. This fluid, yeah, in the lung, yeah, and they end up getting ARDS, acute respiratory distress syndrome, and this itself is what leads to patients needing really intense ventilation. You'll even like this is a very bizarre scene for a lot of people. You'll flip them, so it's very it's not a common thing for people in ICUs to prone someone. It's called proning. When you take them and you flip them so that their lungs are kind of just hanging so that there's more room for them to kind of expand and heal. It's not a common thing we do, but we're doing this often with these coronavirus cases.
Yeah, you gotta do what you gotta do. If that's the only solution, then
Yeah,
you
yeah.
have to do it. So, I have lots of questions coming in. I'm gonna
Go for
try
it,
to
yeah.
ask as much as I can.
Of course, yeah.
So, so what is the latest guideline regarding COVID-19 patients with CV issues who take ACEI and ARBS, considering virus surface respirator interaction with ACE?
I'll explain it. Yeah.
Okay.
So
Yeah.
the virus, the COVID-19 attacks. So the way viruses work is basically viruses will attack a specific type of tissue because that's the only type of cell that they can get into. So
Mm-hmm.
for example, this virus has a key on it that opens a very specific doorknob. The doorknob is ACE2, ACE2. It's a protein that we have on very specific tissues. Our lung tissues have them. The back of our throats are thought to have them. The virus cannot go and infect your skin. It doesn't have the key to unlock the proteins in your skin cells, so you don't get a rash typically with coronavirus, like you would with other viruses that can infect the skin. So that's a topic called tropism, when a virus infects a specific tissue. This virus opens up the ACE2 doorknob, gets in and replicates. ACE inhibitors are things that people take for hypertension, for high blood pressure. There's a thing called ACEs and ARBs, ACE inhibitors and ARBs. These are two medications that people can take for high blood pressure. The thought initially was that why don't we give these patients an ACE inhibitor? Because it blocks ACE2. And if you block ACE2, you can end up kind of preventing the virus from getting in. All of that has kind of been debunked. It's not that it's been debunked, it's that we haven't seen any true data about that. So there is no guide. I don't know of any guideline that exists with regards to whether or not you should take ACEs or ARBs, specifically for coronavirus. What I can caution you is that you should not be making that decision yourself, and that your doctor needs to do that. Because if you stop taking your antihypertensive medications, you can have side effects from that. And then also, if you just start taking an ACE inhibitor to try to fight coronavirus, there have been mechanisms where you get a worse infection. The thought behind that is that when you block the ACE2 receptor, your body will produce more. And as soon as you stop taking a dose, all of these ACE receptors are open, the virus can replicate like crazy. So I would not advise anything with regards to that. I would talk to your doctor, and it would just usually just be with regards to, are you having high blood pressure or not? Should you take your ACE inhibitor? Not related to coronavirus.
Okay. I mean, that was like, wow.
Good question. Good question. Yeah.
Yeah, it was a good question actually. I was just Googling because I didn't know the abbreviations.
Yeah.
So now someone is asking about herd immunity. What do you think about it?
So herd immunity is it's a very important topic in virology and in epidemiology. Herd immunity is basically like you have enough of the population infected where you wouldn't necessarily need to quarantine, A, and then B, it's that most of the population's already seen the virus, so it can't spread nearly as quickly as if no one in the population has it. Herd immunity, you reach around 70 to 80% of the population is infected. You need to infect that many people, or you need to vaccinate that many people for herd immunity to exist. So we're not even near herd immunity yet. We're like
10%?
Very far away. Yeah, we're very far away from herd immunity. You'd need to vaccinate a ton of the population, or
Right.
a ton of the population would need to be infected for this virus to kind of just dwindle as opposed to peak. Yeah.
Interesting. So another question is about the curve. Is it already flattening based on what you see at the hospital or not?
Yeah, I think so. I think first of all, we're blessed in LA. For those of us that are watching from LA, we're blessed in LA because LA is a commuter culture. We're nothing like New York. When you go to get groceries, you don't run across 50 people and walk on the sidewalk, take a metro to go get groceries. You just get your car, you get in, and you might not even have to interact with anyone to get your groceries except for the cashier.
That's true.
In New York, other countries, Italy too, they're stacked on top of each other. There's, you have to walk around, you have to go public transportation, so they get it real bad. The peak has flattened a lot, especially in California, and we've done a fantastic job of that because people are staying home. There are estimates by the LA County where if we don't stay at home, or if we didn't stay at home, 95% of LA County people would be infected by August 1st, which is scary because we don't have enough hospital beds for that many people. When you talk about things from the hospital perspective, nationally, we're seeing a lot of hotspots that are brewing in places that didn't quarantine. And then places like LA, you're not seeing that many crazy patients number of patients, because of the fact that we've done a good job of right now kind of keeping the virus at bay because people aren't seeing each other. You're not allowing the virus to spread because you're not seeing a ton of people like we used to. So yeah, that's what I would say. Hospital-wise, I mean, across the nation, we're seeing more coronavirus cases and less other things. So you're not seeing the typical heart attacks, strokes, broken bones, because no one's doing anything. Everyone's stuck at home. So you're not seeing a lot of the crazy stuff that we're used to in the ERs nationally.
Right. So I have one more question about the symptoms. They're asking if they range from minor to causing death. I've read about this already myself, but would appreciate it if you would explain again. So this
Oh,
is yeah. So they're asking if there is any kind of symptom range basically among the
yeah,
patients.
it is a spectrum of symptoms. So
Hmm.
you have people all the way from almost no symptoms, like I just have a dry cough and it's very light, and that's coronavirus, like you have coronavirus, to patients that come in, have a little bit of a low O2 sat, within 2 hours are dead, are
Uh-huh.
coded, completely coded. Or you have patients like the ones that get the pulmonary emboli where they walk in and they immediately code because they have a massive clot because of coronavirus. So there's a huge spectrum of in between. The main thing is that the typical patients of coronavirus are people that need oxygen, and their body will kind of recover, but a lot of these people can go downhill really quick, so you have to watch them in the hospital.
Hmm.
Yeah.
Yeah, makes
And then
sense.
recovery too is unclear. It's unclear whether people fully recover. People are saying that a lot of scientists from Italy, a lot of the doctors from Japan, I mean from China, are saying that people will lose pulmonary function. Typically, the hospitalized patients are losing a good amount of pulmonary function, about 30% after discharge, and it's permanent
Right.
because of scarring of the lung airways.
Yeah. Yeah, I've heard about that. 20 to 30% like lung capacity basically they're losing it.
And that's like you smoked for like 10 years, a pack a
10
day.
years.
That's a
Yeah,
lot of
yeah.
that's a lot of pulmonary function for you to lose. It's not a small number. 20 to 30% when it comes to your organ capacity is huge. That's like me saying
Right.
your heart is not pumping 20 to 30% as well as it should. That's heart failure. You
Right.
have heart failure if I say that. Yeah, that's
Yeah.
horrific. Yeah.
Oh wow. Wow. So I have one more question. It's again technical. I'm gonna try to
Yeah.
read it. So they're
Okay.
asking any guideline, any guideline to control. I think it's called cytokine storm.
Cytokine. Yeah.
Cytokine storm in COVID-19.
So again, there are no guidelines. I just want to clarify that with everybody. There are no strict guidelines with regards to any of these types of things because no one has good data yet. Physicians make guidelines whenever there's clear-cut data. So even hydroxychloroquine, no clear guidelines. People are using it experimentally typically, or and a lot of these medications people are using compassionately because there's no other option. When it comes
Right.
to the cytokine storm, what cytokines are is they're little proteins that your body releases to induce an immune response. So we have a ton of these cytokines. They're called interleukins. IL-6, interleukin 6 is thought to be the main one. It's an acute phase reactant is what we call it. It's a protein that induces a rapid immune response. So if something's going
Right.
wrong, IL-6 gets secreted, your body's like, let's go fight this, whatever it is. So it gets like it's basically calling the army immediately. It's like launch your nukes, like we're here, we need to fight. So there are medications that target IL-6. There is no guidelines about them, but there are at least two that I know of, medications that have come out that stifle specifically IL-6.
Okay.
And we're seeing some results from these. There isn't enough to be definitive, but we are seeing some results, thinking that maybe it is just your immune response that's leading to death.
Mm-hmm.
ARDS is typically an immune reaction that you mount. You kill yourself typically from ARDS because your body launches this massive fight against your lungs because that's where the virus is.
Right.
Yeah,
Right.
good question.
So yeah, another question is about the and expecting another peak or not in maybe October or November. So we hear it a lot.
Yeah, fantastic questions. So this is, and you could tell you have a very good intellectual base of people watching. A peak will happen if we lift quarantines.
Mm-hmm.
Like it will peak if there is no vaccine, if there is no treatment, and we lift quarantine. The reason why it will peak is because, again, 90+% of the population is probably not infected. We don't have perfect numbers, but we can at
Right.
least say that a huge amount of the population has not had coronavirus.
Right.
If
So
we let people out, you will have a peak higher than the one we just had because a lot of the population is not affected. So it's almost like, starting over again. There will be
right.
some of the population that got over it. They might be immune. The other thing too is that we're not entirely sure whether this virus can reinfect you. We're not
How long?
entirely sure
Yeah.
if you can get another strain that you
Mm-hmm.
didn't see before. I could have gotten coronavirus, gotten over it, and then tomorrow get coronavirus again if it's a different strain. That's what people are thinking because people
Right.
have gotten reinfected.
Right.
Unlike the flu, unlike other viruses where you get it once, you get over it, you're not going to get the flu again. So until we have a vaccine, like we have to be very cautious about how we lift this isolation because
Right.
if we lift it rapidly, you're going to get the virus will spread again.
Right. So, what do you think the next step at United States should be? Should they should just stay? I mean, people should stay in quarantine, basically, from what you're saying.
I don't. So this is the difficulty. This is like everyone's between a rock and a hard place because we
Hmm.
don't have a good answer here. The
Right.
you're juggling the economy with people's lives to a certain degree.
Right.
And I think we did such a good job with this isolation in the U.S. The fact that not, like hundreds of thousands of people did not die is a testament to the fact that people stayed at home. No one's done this before, but we did it. We stayed at home. Um,
Right.
so it's going to be very difficult to say. What I think is a magic bullet to a certain degree that people are now starting to realize is wearing a face mask all the time. So if you think about it, how do you spread the virus? Through your air secretions, right?
Right.
So whatever you breathe out, whatever you cough, whatever you sneeze,
Hmm.
that's how you spread the virus. If you wear a mask, you're going to lower that a ton. And you're also going to filter whatever you're breathing in. So I think if everyone wore a mask, it might be a lot easier to raise the isolation or quarantine. Do we have enough masks? I don't think so. People are making cloth masks now at home with sewing machines and stuff. I think it's a good idea, but depending on the material you're using, I don't know how effective it is.
Yeah.
So, we're gonna have to see how this is gonna work out. But I don't think the answer is like everyone go out tomorrow and live your life like you used to. I think it's gonna change a lot.
Right. So I heard there is some kind of vacuum bag material that they say it's after N95s. That's the best. That has the best filtration. But I have to look it up. I'm not sure about the name of the fabric. Correct? Like the exact name.
I've heard of, so there's I know what people are doing from hospital materials. There's a
Right.
material that we use in the operating room a lot. It's like this blue fabric that
Right.
filters as well as, if not a little bit better than N95 masks. And it's something that we typically throw away. It's something that you wrap your surgical tools in. It's a sterile thing, and we just throw that away because we're not going to use it in OR. But that material itself is proving to be very good at filtering things. So a lot of anesthesiologists are finding ways to use that. I know we use that fabric often in the OR, in the ER, like it's something that we use often. So there are fabrics out there that filter well. It's just a matter of,
Interesting. So they have to be, if they're making their masks at home, they have to just make sure that they're using the right material. Maybe like look it
if
up to.
you're using, yeah, if you're using like, thin cotton, you're not going to filter nearly as much as if you're using a
Right.
thicker, you know, material. So there's
Of
that too, which
course.
is practicality. Yeah.
Of course. So another question about is testing everyone. Basically, what is the idea behind testing everyone? Obviously, it's good to know who is infected, but one could be tested and be okay when tested and then have the virus next day. So, and the continuous testing basically is not a sustainable model. What
I
would you say about
disagree. That's wrong. Um, so look at South Korea.
that?
South Korea tests everyone.
Right.
If you look at South Korea, they are the gold standard on how to have handled this virus. Test everyone, know who's positive, tell them to stay home. So you can change a lot of the way that we've handled this if you test everyone and either tell them A, you have the virus, or B, you've been exposed and now you're immune to the virus. You can
Right.
handle things very differently. We're working blind if we don't have enough testing. And that's how we were working a few weeks ago. 2 weeks ago, we were working blind. We don't know who has it. We can't test everyone for it. So it's a very bizarre situation to be in, but I disagree that, like mass testing is a bad idea. I think if we had the capability, everyone should be tested for whether or not they have coronavirus. And then everyone should also be tested as to whether or not they are immune to coronavirus. Not
Hmm.
only will that give you data about how deadly the virus is, it'll also tell you who needs to stay at home, those that have coronavirus, and you can isolate people specifically. Because if you're asymptomatic and you have the virus, you're spreading it all the time because you think you're healthy, you think you don't
That's
have it.
true. Yeah,
If
you're
you
a carrier.
people, put them at home, be like, hey, you need to stay at home because you have it. And you'll get rid of a lot of the viral burden just in the communities. And you might be able to get people out to work, the ones especially that are immune. So that's one way to handle this if we could test everyone for those two things.
So there is, I had to look this medicine up. So have you had experience with so it's called, I think, tocilizumab
So
or
tocilizumab, yeah, there's a few of them. So tocilizumab is one. Remdesivir is another. There's a few medications. The two classes that we're seeing these things become is, again, is it going to block? One of them is an interleukin-6 blocker. It blocks IL-6. And then the other one is an antiviral medication that was initially designed for Ebola. Those are the two classes that we're seeing. Do I have experience myself? So I can't speak on behalf of like what I do at UCLA, but I could tell you that I have seen remdesivir used, and tamsulosimab is also another medication that we're seeing used frequently too across the nation. And these things are medications that are typically used as a compassionate use medication. What that means is that we don't have enough data on the medication, but because for a lot of these really sick patients, they have no other choice, it's either death or these medications, we're using them compassionately, essentially.
Right.
So we're using them as like we don't care about the side effects right now because you'll die if we don't give it possibly.
Yeah, it's just the last resort, basically.
Kind of, yeah. Until we have more data, yeah.
Right. So another question is about the strains. Has there been any other strains aside from S and L?
Yeah, so there's now 3 strains that are known.
Okay.
And I caution the use of strains. So I studied virology in medical school. I did a bunch of viral research on one of the like most deadly viruses, polio, and then how it infects human cells. And whenever you look at strains, it's almost a misnomer. This virus has had over 100 mutations. So if you look at it that way, this virus has 100 strains. Like there's very many different types of coronavirus right now. COVID-19, there's many different types of COVID-19. If you look at the ones that are populating the most amount of people, there's 3 main ones. And now we've gone from the LNS to ABC. It's kind of simplified. So there's like COVID-19A, COVID-19B, COVID-19C is what most of the scientific community is using now. What we're waiting to find out is, do these different types of coronavirus, A, B, and C, infect different populations? For example, why did in Italy a bunch of old people die when in the US we saw a lot of young people die and a lot of young people go to the ICU? What's the difference there? Is it a strain difference? So, or is it the type of coronavirus difference? So there's a lot of research that needs to be done, but this virus is a kind of a worst case scenario virus. The reason why I say that is because it's an RNA virus.
Right.
So if you look at virology, if you look at just basic sciences, DNA is 2 strands, and you have an original copy and the copy of that original copy. Every time your cell replicates, it looks at that second copy to make sure it didn't make a mistake. So if they made a mistake, it'll fix it. So that way you have another cell that's very identical to the last one you made. RNA viruses or RNA cells, or they're mostly viruses, RNA viruses just have a single strand, and when it makes a mistake, it doesn't know because it can't compare itself to anything else. If it made a mistake, there is no, like, let me go check what the right answer is and come back. It can't do that. So it keeps the mistake. So this virus replicates really well because of that. And I use this analogy a lot. It's like whenever viruses replicate, they're replicating in the trillions. You know, these viruses, your body, when you have a large viral load, when you get infected with coronavirus, you have like millions of virus floating around you. If you take like a simple copy of like, you know, a paper with like a drawing on it, and you put it in a photocopy machine and you make 100 million copies, you're gonna have a lot of copies in there with a little splatter of ink here, a little weird thing here, you know, a lot of mistakes. You take those mistake copies and you replicate that again, you get a whole set of this new bizarre looking, you know, virus. So that's what's happening with coronavirus. Once you make a mutation, you can replicate that. So, and there's not to make it too complicated, but there's evolutionary forces too. The viruses that replicate the best don't tend to kill people. The reason why is because once you kind of kill a host, the host doesn't do a good job of spreading it because they're dead. The best viruses are viruses that get you really sick and have a large viral load for you to give, but they don't typically kill you. So like things like Ebola, they're not very good because by the time you've developed symptoms, that's typically when you're shedding and you die. Like no one's gonna go and be close to an Ebola person because you're bleeding out of every orifice. So the virus doesn't do the best job of spreading. Things like this where coronavirus, with the latest coronavirus, it's really good at spreading because it doesn't kill everyone. That's why it's a pandemic now. And the other thing too is that, you know, the people that it does kill, it does it way later. So it's a really interesting thing, yeah.
I mean, the incubation time is very long. That's
Oh yeah,
also another issue. I mean,
people
14 days at least. I'm up to 14 days basically.
some people have been carrying it for 37 days, has been reported in the scientific.
Wow,
37
wow.
days of carrying coronavirus. That's a lot of time.
But then spreading it everywhere.
Yeah, who knows? I mean, in
Yeah,
a month, how many people do you meet? And if you were living in a regular world without isolation, you'd shake the hands of 1,000 people in a month. You'd be
that's
meeting.
true. That's true. And you touch stuff and they touch the same thing, like door handles, anything.
Right.
Wow, that's insane.
Yeah.
So, I have another question. So, they're asking how likely is someone getting infected through fomite and such as like delivery packages or groceries or anything that they're just, delivered to their homes, basically.
It's a good question, and we don't have an answer for that because it
Mhm.
hasn't been studied well. So we do know that the virus can survive on certain materials for up to 72 hours. We do know that it could stay in the air for about 3 hours after someone has it. And we know that it could spread up to 13 feet from a person who's just standing stationary. So we know a lot of the parameters of the virus. We don't have good data on like, hey, how many people got infected because they touched a UPS box. You can't, it's very difficult to study those things because you need to go swipe people's UPS boxes that they touched 3 days ago. Like you can't do it. It's impossible to study. I think the coolest way to study it would be by genetic tracing to see, do you have the exact identical type of coronavirus that the person who touched the UPS box did or something. But again, these are costly things that I don't think anyone's going to do. So it's
Right.
difficult. But fomites do exist. We know fomites because of the flu. Like I mean, fomites are something that exists with every infection, with every
Right.
type of virus and even many bacteria. A fomite is an object that a person with a pathogen touches, and now
Hmm.
that object is a fomite. It carries the pathogen for you to get it from.
Right.
Yeah.
Right. So, another question. So they're asking the titer test for antibodies is considered more accurate. Why?
And more accurate than what? The original?
I don't know. That's the question. Probably the original. I don't know if there was any.
The titer test is it's a very specific test. So the titer antibody test will test whether or not your blood has circulating antibodies against coronavirus.
Hmm.
What that tells us is that you have seen coronavirus, you've fought it, and your body now has an immune response against it. We're not sure if it's an immune response against every coronavirus, against every COVID-19, but we know that specific types of coronavirus you probably have, like you saw, and you mounted an immune response. It's a really important test because it answers two questions. A, you've seen it already, you've had coronavirus, and then B, you're likely immune to it. I'm not going to say you're fully immune to it because again, we're seeing people getting reinfected. So it
Right.
is a really good test. And recently we're seeing tests now that are like an hour or two turnaround. It's not mass produced yet, but we're seeing these things floating in the pipeline. Typically a titer test is a blood draw. It's something that takes 1 to 3 days to come back. And they
Right.
count how many antibodies you have, and they see, is it good enough to fight another infection?
Hmm.
What we're seeing now is people are making like point of care tests where they prick your finger, they get a little blood, kind of like people that check their blood sugar for diabetes,
Right.
and they test it. It's called an ELISA test.
Yeah.
And I think we're going to see that mass produced very soon. I think that's going to be the gold standard of how we're going to get out of this quarantine, because people
Right.
that are immune are probably going to be okay to go back to work without any issue.
Yeah, and that's gonna basically, I mean, help the economy rolling, but
Yeah,
hopefully, I
and
mean, we'll get
hopefully,
there.
yeah,
Yeah.
we'll have to see.
So, I have more questions coming. I'm gonna just selectively pick like a few. So, considering how many times this virus has mutated, what purpose would a vaccine have, given that by the time it's distributed, the virus would have been mutated again?
I love these questions. I'm just going to throw that out there. Excellent question, because this is the fear on every virologist's mind. Coronavirus, you typically can't vaccinate against. And this, I'm not talking about COVID-19. I'm talking about coronaviruses in general.
Hmm.
A little history about coronaviruses. There's 6 main types of coronavirus. 3 of the 6 cause the common cold. So how many times do we get the common cold in our lifetimes? Probably 100 times. Imagine you've gotten probably the common cold like 30 or 40 times by now. Your body still cannot fight the next common cold, even though it's a coronavirus. So not even your own body that's seen this thing 40 times can fight the new one because it's mutated a little bit. Vaccination depends on the fact that viruses won't change too much. So
Right.
we can vaccinate against Ebola, we can vaccinate against measles and mumps and all those things because we don't expect there to be much change.
Hmm.
When you look at coronavirus, it's really crappy because again, it's a single-stranded RNA that is known to change. So we don't have a vaccine against SARS that's like rapidly available. We don't have one against MERS, which are the two other strains.
Hmm.
So whether or not we're gonna be able to come up with one for COVID-19 we're gonna have to see. This is uncharted territory for virology because we're being pressed to produce a vaccine on a virus that's known to be difficult to vaccinate against. Will we be able to do it? I think that given the fact that there's so much attention on this virus, we're gonna have to be very creative and we might be able to find a way to vaccinate against it. But it's just a matter of will we be able to?
Right.
Yeah.
Yeah, that makes total
But it's a
sense.
good question. I mean, yeah, we're
So,
gonna have yeah, go for it.
I mean, it's something that I'm sure everybody thinks about it, whoever is working on this
Yeah.
vaccines. So, one more question is about the oh, this is interesting. I've seen this. I've read an article about it basically. So, they're asking if there is any observation or study between individuals' blood type and the infection.
Another good question. So there have been some studies. Um, it's not true fact. Like it's not. We don't have enough data to make a definitive statement on. Is how I should word this.
Mhm.
But there are some studies that suggest that type A blood groups are at a higher risk of infection, and type O blood groups are at the lowest risk. If you know much about blood types, let me just give like a little one-liner. A type A blood group, you have a red blood cell with a little protein, we'll just call it A on it, okay? A type B has the B protein on there. Type AB has both, and type O has none. So whether or not this virus can also use that type A protein in a way that helps it get into a cell is unclear.
Mhm.
But we are starting to find out that this virus can also change the protein structure of hemoglobin. It could
Oh,
affect red blood cells. And that is thought to be a cause of death too, because if you can't oxygenate, if you can't carry oxygen in your hemoglobin, what's your blood worth? You know, it's not.
obviously. Yeah.
So there are some studies coming out with that, with no definitive ones yet. And again, what if it's only one strain that can do that and the other two strains can't, or the other
Right.
100 strains can't? So it's very murky until we figure out what strain's doing what and how it's infecting what,
Hmm.
and that's how we're gonna have to find out.
Interesting.
You know.
So, have you updated your approach to, oops, they are sending me questions and the questions are moving up, so I'm just losing
Yeah.
the location. So, have you updated your approach to evaluation and management of patients to the ED with suspected COVID-19? I believe that was supposed to be ER instead of ED, if I'm not
Yeah, ED
mistaken.
means emergency department. Yeah, yeah.
Okay, so the
Yeah.
same. Yeah.
We're not rooms anymore. We're just really
Right.
large. Yeah. So my approach and a lot of the people's approaches nationally is now treat everyone as if they have coronavirus because
Mhm.
we don't know. We don't know if they're asymptomatic. We don't know if the diarrhea is from coronavirus. We don't know if it's, like there's so many symptoms with this thing, it's unclear. So we're treating everyone like they have coronavirus, and then we're taking things from there. If typically across the US, if they're going to be admitted to the hospital, they will get a coronavirus test to see whether they need to go to the coronavirus unit. So most hospitals now have a coronavirus unit where only coronavirus patients stay so that we don't infect other non-coronavirus patients. Because a lot of patients in the hospitals are immunosuppressed, they don't have a good immune system, they might have other comorbidities that make them highly susceptible to a very bad outcome if they get coronavirus. So that's what most hospitals are doing now. When it comes to
Right.
treatment wise, a lot of the ways we practice medicine have changed for coronavirus. We don't try to bridge people on oxygen typically if they're starting to have airway issues. We'll typically just intubate them. We won't waste our time trying other less invasive treatments. We will intubate them and put them on a ventilator because a lot of the studies are showing that that might actually help, and
Right.
also just to decrease the risk to everyone else in the hospital. Because every time you use like a face mask oxygen, you're spreading particles everywhere. Every time you put like a BiPAP machine, you're spreading particles everywhere. So we'll just put a tube in which secures their airway and prevents viral spread around as well.
I can understand that. Well, I'm gonna wrap this up because I still have some questions, but there are a lot more coming. I tried to ask most of them as much as I could read because they're
Let's
just
do
moving up.
three more questions if you'd like,
Yeah.
and then we can, if that's okay.
Um, Let me see if I can find one more.
Sure, whatever works.
So they're asking if the if the BCG vaccine for I think it's for
Yeah,
tuberculosis, right?
it's a tuberculosis vaccine.
Yeah, could help create a
Good
sense of
question.
immunity.
So good question. Unfortunately, again, we don't have enough data. And a
Mhm.
lot of the unfortunate thing here too is that a lot of fake news sites are spreading this. Medically, there may be a potential immune response that your body can use that people think might be attributed to the BCG vaccine. We don't have enough studies about it, so I
Okay.
can't say that BCG actually helps you. The unfortunate thing is that a lot of fake news sites are like touting it like, like it saves people's lives. If you look at the people that died in Italy as well as internationally, a lot of these older people had gotten the BCG vaccine, because that was the tuberculosis vaccine of the time, and a lot of them died. So we can't say for sure. Could it give you a little bit of immunity? Sure. I caution I caution people when they think that, there's a magic bullet. Like if I take vitamin C, I'm protected against this. That's not how this works. It's a lot more complicated than that. So I think that what we need to do is aim all of our efforts towards getting an actual vaccine or treatment towards coronavirus, as opposed to kind of think that a lot of these other things might be beneficial. May there be some benefit? Maybe. We just don't know enough yet.
I understand. Yeah. Well, this was very informative, actually. I'm just like flooded in lots of information and I'm trying to process it myself. Um, Very, very, I mean, interesting subject, and I'm sure everybody's very interested in this. We really appreciate it. They're just saying, great job, Hike. Thank you. I mean, people are writing that. So,
I appreciate it. Thank
so
you,
yeah,
guys.
thank you so much. We really
Of course.
appreciate the work you guys do, all the healthcare
Mhm.
professionals, and a big thank you to you guys. I know it's not easy and you guys are under stress and everything. It is a responsibility that you have taken on, but at the same time, it's not at the cost of your own life. And I know so many are risking their own lives.
I
So thank
I
you.
know. Thank you. I know that on behalf of like my colleagues and myself in emergency medicine, we are blessed to do what we do. Like this is literally what we signed up for, and this is something that has like being on the front lines is something that is what we look forward to every day. I know all of us are scared about like catching it or infecting our families and things like that. We're living separate from our families often, but this is literally why we went into emergency medicine, to treat the sickest of the sick and to do everything we can. So we're really grateful to all the support that we're getting, and we wouldn't do it any other way.
Um, Thank you. I have one more question. I don't know. Should I ask this one? Then
Yeah, go
wrap
for
it.
it.
So this is actually from one of our members.
Okay.
Um, they're asking, how can we help as an organization, as a community of scientists and engineers? What can we do?
Okay, thank you so much for asking that question. Initially, I know that there was so much outpouring of support, and people were like, "What can we do?" And what I've seen from the scientific community, particularly the engineering community, is people have 3D printed us like face masks. People have come up with like church groups have come together to sew masks for hospitals, and it's amazing. My mask in the hospital is 3D printed by someone who just donated it to me, and that was like it's incredible. I think that at this time, the best thing to do is to educate your friends and your families, especially, and I say this especially for your organization, because people in your organization, I take it, understand the importance of vaccination. In the Armenian community particularly, there's a huge, huge controversy. There's a lot of conspiracy theories about the idea of vaccination. And I'm fearful that we're going to lose a lot of Armenians in the future once a vaccine is available, because they're going to be like, no, I don't do this. So I think that educating people around you about the science of viruses, the science of vaccination, and a lot of the myths that are coming out about like things like 5G towers and all this other craziness that we're seeing, like I think we are, as a community, need to just educate as scientists, as engineers, as physicians, as lawyers, as anyone that can just educate those around you. That's what I would say. And stay at home for now until we figure out how we're going to handle this.
Yeah, sure. Some of us are working. I'm working, but taking all the precautions.
Okay, good.
So thank you so much, Haig. It was very interesting. I loved it. I'm sure. I mean, I see the questions still coming in, so I know everybody, or the thank yous actually. I know they really enjoyed it too. I'm gonna just direct this one to our audience. Thank you so much for being here tonight and joining us. You can find us on our Facebook page, AESA, or on our website, aesa.org. We're all scientists and engineers. You're more than welcome to join us. We'll be happy to have all of you. And please, again, it's mentioned. Heike also mentioned it. Sorry, I'm not even referring to you as doctor. Like
You don't have to.
I'm very comfortable here. So, so you already mentioned to stay home and keep social distancing. If you have any other questions, anything from our side, our organization, feel free to email us. You can just email us to contact@asa.org or just message us on Facebook. Some of us, like a few of us, are on the Facebook page. We can respond maybe like just in less than an hour or so. So thank you for participating. Thank you, Haig. And thank you for all your insightful answers. And have a great night, everyone.
Thank you, guys. Thank you for watching.
Thank you.